Thank you, sir, for your kind words. Today I will be presenting my topic, PCOS and type 2 diabetes, breaking the vicious cycle. What is the agenda of the talk? First are the introduction, the risk factors, what is the pathogenesis of insulin resistance in a PCOS patient, how do we diagnose and evaluate a patient for insulin resistance in a PCOS patient, management, and final tips. Introduction. PCOS is a multisystemic disorder usually seen in females who are in their reproductive age. Diabetes mellitus is caused by body's resistance to insulin or a deficiency of insulin synthesis from a pancreatic islet cell of Langerhans. PCOS exhibits insulin resistance and hyperinsulinemia, which makes it a pre-diabetic state. Type 2 diabetes and glucose resistance may result from total compared insulin insufficiency, which can happen if the beta cell's compensatory response slows down with time. So what are the factors which can lead to what are the risk factors which can lead to dysglycemia in a woman with polycystic ovary syndrome? Some of the most common risk factors being metabolic gene clusters, obesity, hyperandrogenemia, sedentary lifestyle, endocrine disruptors, sleep disturbances, any family history of type 2 diabetes, mood disorders like depression, any patient on OCP treatment or vitamin D deficiency. These are the negative factors which can affect dysglycemia in a woman of polycystic ovary syndrome. This graph shows about the gradual improvement of insulin resistance over the years in a normal weight and overweight woman with polycystic ovary syndrome, but not in their obese counterparts. So what are the symptoms of insulin resistance which commonly we see in a patient of PCOS? Patient can have craving for sweet and salty foods. There can be darkening of skin in the groin, armpits, or behind the neck. There can be increased hunger or thirst, fatigue, frequent or increased urination. So how do we link PCOS with increased risk of type 2 diabetes? What is the pathophysiology behind it? First is insulin resistance. It is seen in about 50 to 80% of PCOS patients. We say insulin resistance when the fasting insulin levels are more than 20 international units per ml and postprandial being more than 55. And acanthosis nigricans is a clinical manifestation. Beta cell dysfunction has also been one of the established risk linking the path of increased risk of diabetes. Genetic links for us is FTO variant gene, which results from a variant of FTO on the fat mass. So what is the vicious, before breaking the vicious cycle, we need to know what is the vicious cycle which links PCOS with insulin resistance. Genetic and lifestyle factors lead to insulin resistance in a case of PCOS that leads to hyperinsulinemia. Hyperinsulinemia in a patient acts on liver to decrease the sex hormone binding globulin and decreases the insulin-like growth factor binding protein 1. And it also acts on pituitary hormone to increase androgens in ovary cells by decreasing by follicular destruction. All these factors together lead to hyperandrogenemia. Hyperandrogenemia, in order, it acts on the visceral adipose tissue, increasing the free fatty acids, which consecutively leads to hyperinsulinemia in a patient. Why do we see insulin resistance in a case of PCOS patient? There is a post-binding abnormality with the abnormal autophosphorylation of the beta subunit of insulin receptor and insulin substrate 1. There is also decrease in tyrosine phosphorylation and an increase in serine phosphorylation, which reduces the insulin metabolism. There is involvement of cytochrome P40C7 in androgen formation, which also plays a role in abnormal insulin receptor and IRS1 phosphorylation. It induces thicker cells to synthesize more androgens, resulting in dyslipidemia. So how do we diagnose a case of insulin resistance in a PCOS patient? The gold standard being the glucose clamp technique that is used in vivo. The amount of glucose injected in the steady state is equal to the amount of glucose absorbed with the peripheral tissue, which can be used to measure the peripheral sensitivity to insulin. But the major drawback that it is very time consuming. So we have other effective alternative quantitative indicators of insulin resistance, such as BMI, waist circumference, waist to hip ratio, waist circumference and other anthropometric markers, fasting insulin levels, oral glucose tolerance test, glucose insulin ratio, and homeostasis model assessment of insulin resistance, that is HOMA-IR, and quantitative insulin sensitivity test indexed, and lipid to lipoprotein ratio and other biomarkers can also be used. These indices are reasonably correlated with each other, and with the gold standard clamp technique, HOMA-IR is the best and the most widely validated marker, but the cutoff points are still not universally accepted. So what are the new markers of insulin resistance that are still in the study phase? First is adiponectin, which are secreted by the mature adipocytes. Decreased plasma levels is associated with increased insulin resistance and increased BMI in PCOS patients. Resistin is also secreted by adipose tissue. It links obesity with diabetes, but its role in insulin resistance of PCOS is still controversial. Another one is leptin. Leptin is also secreted by adipose tissue. It negatively correlation is there between insulin sensitivity and leptin levels. Some of the other biomarkers which can be used are visfatin, vaspin, epilin, copeptin, irisin, plasminogen activator inhibitor 1, that is PAI1, and zonulin. They are still in the study phase, not approved as insulin biomarkers. So what are the guidelines regarding doing oral glucose tolerance test in a case of PCOS? According to Royal College of Obstetricians and Gynecology and International Diabetes Federation, any patient in which we can see one or more criteria, that is BMI more than 25, age more than 40, previous history of gestational diabetes, or any family history of diabetes, it should be done at the time of presentation. And if the patient is having impaired glucose tolerance or impaired fasting glucose, then it should be repeated yearly. How do we manage a case of insulin resistance in a case of PCOS? Non-pharmacological management is there and pharmacotherapy is there. Non-pharmacological management being the mainstay of treatment. Lifestyle modifications are suggested, which includes dietary change and regular exercise. Patient is recommended to use fruits, non-starchy vegetables, low-fat dairy products, lean meats, omega-3 fatty acids, nuts and seeds. And he's avoided to use sugar and trans fats, saturated fats, moderate alcohol, salty foods, processed foods. Patient is also advised for regular exercise to engage in at least 150 minutes of moderate to high intensity exercise weekly, such as brisk walking or cycling, to improve insulin sensitivity and to aid weight management. What is the pharmacological management for us for treating insulin resistance in a case of PCOS? First is metformin. Its major effect is to decrease the hepatic glucose production, thus reducing the need for insulin secretion. It also decreases intestinal absorption of glucose and improves insulin sensitivity. The guidelines will also recommend the use of metformin in any obese insulin-resistant woman with PCOS to manage weight and endocrine and metabolic disorders in conjunction with lifestyle adjustment. Mechanism of action being increases the translocation of GLUT1 and GLUT4 to cell membrane, activating the AMK signaling pathway, and reconstructing the role of endogenous insulin sensitizing molecules such as adiponectin in endometrial tissues. Other true insulin sensitizers that are present with us are PPR gamma agonists. They are used for hyperinsulinemia and insulin resistance in both lean and obese patients with PCOS. It also helps in improving abnormal glucose tolerance, hyperandrogenemia, ovulation disorders in women with PCOS. Major adverse effects seen are weight gain, hepatotoxicity, increased risk of coronary artery disease, and myocardial infarction. Some of the other drugs that are approved are GLP-1 receptor antagonists, DPP-4 inhibitors like sitagliptin, sodium glucose cotransporter type 1 and type 2 inhibitors. SGLT2 inhibitors like dapagliflozin play important role in glucose homeostasis by reducing hyperinsulinemia and improving insulin resistance by acting on glucose absorption in the gut and kidney respectively. So the major drugs available with us are metformin, pioglitazone, rosiglitazone, GLP-1 receptor agonist, DPP-4 inhibitors like sitagliptin, and SGLT2 inhibitors like dapagliflozin, empagliflozin, out of which we are practically just using metformin for treating insulin resistance in a case of PCOS. Other supplements which have a role in managing insulin resistance in a case of PCOS, alpha-lipoic acid, omega-3, coenzyme Q10, vitamin E, probiotics, carnitine. They act by anti-inflammatory and antioxidation effect. Thank you.